That probably is an issue of patient selection, but was a pretty consistent finding. There has been one more recent study since that meta-analysis was published, and this is the Cleveland Clinic experience, looking at just their consecutive series of patients who were diverted and not diverted, and they found really very little difference in any of those factors, pelvic sepsis, anastomotic leak, or fistula formation, and if anything, it seemed that the patients who were not diverted did better. If you all want to come down and sit here, don't worry about interrupting me. There is the trouble with all of these trials is that, as I alluded to, we're not really comparing the same group of patients, because the people that we do this procedure on without diverting them are typically healthier, and this operation may have gone more smoothly. There is one randomized trial, and which was published now quite a while ago. It was again in carefully selected patients that were not on steroids and had a double stapled technique. And in this randomized trial, there was no difference in septic complications. There were a significant number of stoma-related complications, and these authors argue that in carefully selected patients, we should try to do it without a stoma. So in reality, how does that get translated for most surgeons? And I think what I and many surgeons tell patients is the perfect patient, the perfect operation, and you can go without a stoma. So if you're reasonably healthy and your nutrition is good and everything about the operation goes technically perfectly. It's an elective planned operation. We don't have any significant bleeding. We have complete intact doughnuts from the staple line, and there's no air leak when we test the anastomosis. Those are essential conditions. There's another subset of sort of desirable conditions for avoiding the stoma. In an ideal world, they wouldn't be on steroids, but of course, other than dysplasia, at least historically, if you needed an operation, you were most likely going to be on steroids. The patients who had a previous subtotal colectomy with an ileostomy and a Hartmann seem like good candidates. If they're thin, which the enigma, at least in Minnesota, in IBD is how we have so many heavy overweight patients who are supposed to have this weight-losing, wasting illness, and women, and certainly FAP over ulcerative colitis. So the emerging consensus in the surgical world about pouches has been that almost everyone gets a J pouch as opposed to a total proctocolectomy with an ileostomy, and certainly as opposed to a continent ileostomy, that we do a double staple technique, and that if they meet those criteria, that we would do this as a one stage. So why am I calling this still a surgical dilemma? Well, there are still issues. But I've skipped ahead, so we're going to backtrack just a little bit. The other thing that's come up is whether laparoscopy is the solution to some of these, just for this subset of patients. It makes the operation less morbid. Most studies, there are now a lot of studies doing both total proctocolectomies and ileostomies laparoscopically, as well as J pouches. Most of them report an equivalent morbidity and reoperation rates. They're almost always longer operative times, but often shorter hospital stays. So the emerging consensus now, in addition to those previous three things, is that when it's surgically amenable, that we would do a laparoscopic approach. So the question is, why is it still a dilemma? And one issue is what's been found in some early papers, and then this is a meta-analysis from this institution that looked at this issue of fertility and what having a total proctocolectomy and a J pouch does to the ability of women to become pregnant who are in childbearing ages. 8 studies met the criteria for inclusion, and one was omitted because as an outlier. And what they found was that in medically treated patients with ulcerative colitis, there was, even just from the illness, some infertility, but it increased 3-fold after an ileoanal reservoir. Obviously, this gave everybody pause about whether and I think probably made for more aggressive medical management to try to avoid an operation in this population. There has been one study published since that meta-analysis was done that looks at this issue. These results are a little less pessimistic. This is a questionnaire study of 160 women after pouch procedure and 160 women who had just an appendectomy and served as controls. There was a quite good response rate to the questionnaire. And as I mentioned, these results, while there is a drop in the rate of getting pregnant after a pouch procedure compared to controls, and a drop in carrying the pregnancy to term, it's certainly not as grim as only 50% of women being able to get pregnant or carry a child to term. There is some data in a small studies looking at doing hysterosalpingograms in these patients, trying to figure out why it is that they had trouble getting pregnant. Not surprisingly, what was found is that a significant percentage had occlusion of their fallopian tubes, or some had just dense adherence to the pelvic floor, which obviously would impair fertility. So this raises the question of what should we be doing in those patients, young women in childbearing age, who do need an operation. There's a suggestion from some small studies that perhaps the answer is to do a subtotal colectomy and wait for them to finish their childbearing years before proceeding. There's obviously some downside, leaving a diseased rectum in. But in this small study, 10 out of the 15 patients in whom that choice was made were able to have a successful pregnancy. There's also some data from the FAP literature, and this is a study from Denmark in which through a registry they looked at patients who with FAP preoperatively and then after just a subtotal colectomy with an ileorectal anastomosis and after a pouch procedure. And you can see these are the pre-op and after an ileorectal compared to the reference, so they're at least as good. This is the group after a pouch procedure, so that in that population as well there was a significant drop in fertility or fecundity, but there did not seem to be that same drop after a subtotal colectomy and an ileorectal anastomosis. So most young women who need an operation for ulcerative colitis are not candidates for an ileorectal anastomosis because of the disease in the rectum, but certainly we could do a subtotal colectomy and a Hartmann with an ileostomy until they'd finished their childbearing years. Not all women are wild about that choice, but it's an option. So another option is, or another question has been whether laparoscopy would be protective against these adhesions. And this is a small study that comes from the Mayo Clinic in Scottsdale. And they did a study both in men and women, but I'm just going to present the data on women, in which they did a two-stage procedure. And at the time of closure of the ileostomy, they did a laparoscopy. And they assessed by a grading scale from the American Fertility Society the adhesions in the pelvis. So, and in this subset, almost 3/4 of them had no adhesions in the pelvis. There were some mild filmy adhesions over 1/3 of the adnexa and another quarter, and some had adhesions over a little bit more of another adnexa. None of them had adhesions over both adnexa. Now, this is an institution that does a procedure totally laparoscopically, and I can go back, but most institutions do most of the mobilization laparoscopically and make a small fan and steel incision and do the rectal mobilization and the formation of the pouch open. So it doesn't apply perhaps to every institution, but this data would suggest that laparoscopy may be protective against the issue of pelvic adhesions preventing pregnancy. Then the other issue that's come up is, while we would all agree that Infliximab has made a big difference in terms of the medical management of patients with ulcerative colitis, the question is, what does it do to their risk if they fail that treatment and need to have surgery?